Yeah. Ooh, yeah, I'm good. Hello again. My voice still sounds like this. I'm so sorry. What do you guys think about this font? I like a little bit of a typophile. Like, I love fonts, and I know that for lectures you're supposed to just use like Helvetica and that's it. So I use my title page as like where I get to experiment with fonts. How many people hate this font? Raise your hand. All right, fair. That's fair. So it's about a fourth. Okay. Appreciate the feedback. We're going to talk about meningitis. So with meningitis, I got some good news. The good news is that the incidence is definitely decreasing. We're definitely seeing less and less meningitis, mostly due to these immunizations. The bad news is that even if we see it, even if vaccinations have gone down, the mortality rate is actually still the same. So if we see a meningitis patients, they are as likely to die today as they were 20 years ago. So we have to be able to identify this quickly and know what to do about it. So what is the mortality rate of meningitis? It's still as high as 30%. That's crazy. It's for bacterial meningitis. And even if they survive, a fourth of these patients will have permanent neurologic disabilities, usually sensory neural hearing loss. So this is a significant morbidity and significant mortality disease. Now, as far as the types of bugs that can cause meningitis, our most likely causes are going to be viruses, and then unknown is a kind of a big group. I was kind of surprised about this. The ones that are the deadliest that we care about mostly are going to be these 14% of cases of meningitis, which are bacterial meningitis. And out of these, the most common is going to be strep pneumo, GBS, and Neisseria. So these are going to be your top 3 bugs that are going to cause your meningitis. Now let's talk about symptoms of meningitis. Now this classic tetrad, the fever, the stiff neck, the altered mental status, this is actually only going to be present in less than 50% of your patients. So a lot of your patients are not going to present with all of these. It doesn't mean that you completely forget about these symptoms though. Up to 95% of your patients will have at least 2 of these symptoms. So don't completely forget about it, but understand they're not going to have all of them. But if you have a couple, good story, be highly suspicious of it. Now let's talk about some of these physical exam findings. We learn about these pretty heavily in medical school, right? And these actually do pretty good with specificity. Now this is of course in the setting of you suspecting the patient has meningitis. If you suspect the patient has meningitis, all of these tests are highly specific for meningitis. They're not sensitive though. If they don't have these findings, they definitely could still have meningitis. Let's talk about your workup. There are a bunch of lab tests that you should do, your CBC, your CAP, lactate. I like to get thyroid studies in a lot of my patients because altered mental status of fever and sometimes hypotension can actually be a manifestation of hyperthyroidism, thyroid storm as well, though usually they're hypertensive. But these don't really diagnose meningitis. These are mostly to help you figure out how sick your meningitis patient is or to make sure they don't have different diagnoses. Where the money is actually in your lumbar puncture. You guys know about this movie, right? I have to take this slide out when I talk to medical students because they have no idea, like they've never seen this hilarious movie. If you haven't seen it, please see it, it's great. So before you think about your lumbar puncture, you guys get it? It's a CAT scan. Yeah, before you get your lumbar puncture, there are some times where you have to consider a CAT scan, and that is anytime that you think the patient might have a CNS lesion. The idea is if you do that LP, you might increase that intracerebral pressure just enough to cause that brain to herniate, right, which would be a big deal. There are a couple of historical clues that you can consider that makes your patient higher risk for having that CNS lesion. But the issue with this is that sometimes getting that CAT scan will actually delay the definitive treatment, which is antibiotics. And every hour that your patient does not get their antibiotics, that they have meningitis, they increase their mortality rate. So if you have a patient, you need to get that CT scan before you do the LP. CT scan is going to take a little while. Don't delay the antibiotics. I would go ahead and give the antibiotics before you get that LP. There's one other situation you have to consider maybe not doing your LP, is if they have any kind of risk factors for increased bleeding. So this is an elevated INR, they're on oral anticoagulation, or they have low platelets. These are what most of the guidelines talk about as relative contraindications for your LP. Now, if you want to know more about this really interesting topic, this was a resident of mine, Ann Flower, who wrote this post for EM Docs, and she goes through the literature really well. So if you know a little bit more about this topic, go to this EM Docs page. Now let's talk about the LP, a little bit of practical information. These are kind of the two ways that you can position your patient for it. How many of you guys like the fetal position? Okay, and so the rest of you, I assume it's going to be the sitting up position. Now, I'm kind of with you. I do both, but I like the sitting position better. I find it's a little easier for me to make sure that I'm midline with the spine. It's a little easier for them to curl, I feel, and it's easier to measure the opening pressure as well. Now, this up here is actually not necessary. I know that I was taught that you have to actually bend the neck forward. That actually doesn't matter as much. They've done studies in babies where they found that actually does nothing to increase the interspinous space in the lumbar area, which of course, when you think about it, makes perfect sense. Now, what does help actually if their knees are a little bit elevated, so I like to think about the squatty potty position, or if you're going to be generic, there's also this other one, the poo-poo stool. So if you put their knees up a little bit, that actually will increase that interspinous space. It has nothing to do with the neck. You can do it this way works as well, but some limitations. The big one is it's hard to measure the pressure with that. Now, this is something that you definitely should not do. This is a little mannequin. It's not a real baby, so these are the baby's hips. That's the little shoulder blade. Do not flex the neck, especially when you're doing this in babies. That increases the chances that they will go apneic because they can't breathe because you're smushing their airway, right? So you do not need to be putting your hand on the baby or the adult's head or neck. What you want to do is you want to actually place it behind the shoulder blades, right? Because you got to make sure that you keep that airway open and kind of accordion that back so that this part sticks out. And this is the positioning if you have them upright. Although this I found is definitely doable in the smaller babies. When they get a little bit bigger, it's kind of hard to hold this way just because of size. Now, I think most of us know our landmarks. We look at the iliac crest, draw a line, and the issue that I have is I'll find it, right? It'll look great, I'll drape the patient. And then we have a lot of what I call Kentucky mediums. I don't know if you guys got mediums up here. All of you seem like very healthy people compared to what I have in Kentucky. But so one Kentucky unit is 100 kilograms. So we very easily have 1.5 to Kentucky unit patients. That's kind of like our average, right? So once you lay them down, they're kind of sunken into the bed a little bit. You have a hard time finding that iliac crest again, just to confirm before you stick, right? So one trick that one of my residents, when I was a resident, she was my upper level, brilliant person, taught me is you can actually get your little EKG sticker. After you find it, this is the patient could be sitting up, it could be anywhere, and you just stick the little EKG sticker there, and it's a little metal knob, so you always know where that iliac crest is, and you don't have to push down to try and feel it. So this is what I always do before I drape the patient to make sure that my landmarks are appropriate. Now let's talk about this. Now this is one of my most hated things. You know, somebody's got a bad headache, you're concerned about a subarachnoid, and you're like, hey, I'm going to use this test to diagnose you, make sure you don't have, a subarachnoid. And you go through the side effects, and you kind of go, it could be infection, could be a worsening headache, and they stop you wait, I'm here for a headache, and this procedure might give me a worse headache. Yes, can I still do it? And they say no usually at that point, which is good because then you get out of that procedure. So the issue with post-LP headaches is, of course, that you have your brain, it's in this soup of the CSF, and that buoys the brain. And if you take that CSF out, the brain kind of sags a little bit. That's a theory as to how this post-LP headache works. Now, usually the amount that you take out with an LP is replenished in about an hour. Your CSF is constantly getting drained and refilling. Usually about an hour, it fills back up, right? But you might have situations in which this doesn't happen and you will get this headache. There's a couple of strategies that you can use to decrease your incidence of that dreaded post-LP headache. The first one I want to talk about is the type of needle that you use. You can use these atraumatic needles, which are basically blunt tip needles, or you could use your standard needle, which is a sharp cutting needle. Sharp cutting needles obviously do a lot more of a less ragged cut. These are going to have more of a ragged cut. Now, the predominance of the literature demonstrates that these atraumatic, these blunt needles are actually better in regards to post-LP headaches than the cutting needle. So you definitely want to use that over the cutting needle. Now the theory behind that is that the cutting needle creates such a good sharp line that it doesn't generate the inflammatory reaction that the jagged line of the atraumatic needle does. The inflammatory reaction creates more of an inflammatory response, which causes that hole to close faster because more things are being recruited to fix that thing. That is the theory behind why the atraumatic works better. The other thing is the orientation of the bevel of the needle. Now you have your dura of the arachnoid, and they're oriented in parallel with your spine. So they're going kind of down your spine. And if you cut it parallel with those needles or with those fibers, you're less likely to cause a more broad injury like this as you were if you're perpendicular. What that means is if the patient's laying down, the bevel goes up towards the ceiling. If they're sitting up, the bevel goes towards the right or towards the left. You basically always want the bevel to go off to the side of the patient. That has also been associated with a decreased incidence of post-LP headache. And lastly is the stylet. Try to reinsert the stylet before you suck the whole needle out after you get your CSF. Now there have been studies that show that there is a dramatic decrease in the incidence of post-LP headaches when you reintroduce a stylet. Now this is just a theory, but I'll walk you through this. So you poke the needle in here, and this is using those atraumatic needles. You take the stylet out, you're getting that CSF. What happens is this arachnoidea, or the arachnoid fibers, they kind of get sucked into this hole, which makes sense. If you just pull out the needle without reintroducing the stylet, these little fibers of the arachnoid get sucked out of the hole you made. Since they're sticking out of the hole has a hard time closing because there are things inhibiting that hole from closing. If you stick the stylet back in, these things get pushed out, stay in the spinal column, and then this hole is able to heal faster. That's the theory behind it. Basically, stick the stylet back in, less post-LP headaches. Now, what happens if you, unfortunately, you did everything right? You did the stylet, the bevel off to the side, used a good technique, used the atraumatic needle, you reintroduce the stylet, they still get that post-LP headache. What do? The big one is you have them lay down flat. Remember, the issue here is that the brain is sagged a little bit, and that's what's causing that headache. So if you lay them down, gravity is going to help pull that brain back up just a little bit, and it'll help. You can obviously give them IV caffeine. That's kind of our thing in the ED that we can do. Here is the dose that you want to give. And if that doesn't work, you can do the blood patch, or anesthesia can do that blood patch. Now there is a first pass failure rate that's like 20% or so with this blood patch. If that happens, you just have to consult again and then go to the second one. Usually by the second one, these patients do well. The vast majority do well with one blood patch, so I'm actually need 2 of them to make it work. Now let's talk about the CSF itself. This is a bad color. You want the CSF to be completely clear, not any kind of a tint, especially a yellow tint. This is a CSF sample that one of my residents sent me this year. And you can go through all of these things. I'm not going to kind of go through this because this is very easily Googleable. If you can Google something really easily, there's no really reason to mention it. And this is if you are unable to get your Gram stain back quickly, you can use this to kind of help guide your management as far as which antibiotics or what treatment to give. Now the treatment for meningitis is going to be steroids and antibiotics. Now the steroids you want to give, I give it to everybody who I think has meningitis. Specifically, it's the best for patients who have pneumococcal meningitis. It helps with the inflammatory response, and they have better outcomes as far as morbidity. So they have less like sensory or hearing loss, things like that, down the road if you give those steroids. And the recommended dose is Decadron at 10 milligrams IV. And antibiotics, you should do whatever works in your institution. Where I work, this is usually what we give for undifferentiated bacterial meningitis, ceftriaxone and vancomycin. Now briefly, we're going to talk about viral meningitis. Now this one obviously is less acute, so it's subacute. These guys usually are going to present usually within 2 to 3 days versus a bacterial meningitis, which usually about half of bacterial meningitis patients will present within 24 hours. So these guys are going to have a longer course. It's going to be not as bad. They're really going to present with just like a headache. They might have mild altered status depending on what their baseline functional status is, but they're definitely not going to be as sick as these bacterial meningitis. And enteroviruses are going to be the most common cause. The treatment for this is going to be supportive. These patients don't necessarily need to be admitted. I've sent probably an equal amount of patients home with a viral meningitis as I've admitted. I usually admit if patients have intractable headaches. Nothing I can do can make that headache go away. At that point, I'll usually admit them. The only caveat to that is if they happen to have HSV, that obviously needs to be admitted and needs to be treated. A big hint here is if you're going to have a little bit of blood in your CSF, that is something that should increase your suspicion that the patient has HSV as well. And that is the end of my talk, and we'll take questions afterwards. Thank you.